Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you for having me. And I will be talking to you about psychosis in the context of substance use and how to approach it, and perhaps a little bit about psychosis more broadly. I don't have anything to disclose. This is just the standard disclaimer. So some objectives for today. So we'll talk about epidemiology of comorbid substance use and psychotic symptoms. We'll talk about how to tease them apart and what makes them different, and then a little bit about evaluating and treating patients who present with substance use and psychotic symptoms. So just to start a little bit on the interplay between HIV, substance use, and psychosis. So people living with HIV are at a higher risk of psychotic symptoms. Of course, this decreases with appropriate treatment. We also know that schizophrenia alone does not increase the risk of HIV, but having schizophrenia and using substances does increase your risk of HIV more so than just substance use alone. We know that co-occurring HIV and psychosis is associated with poor access to healthcare, lower quality of life, poor attention and care, and prolonged hospitalizations. And that mortality risk in individuals with co-occurring HIV and schizophrenia is substantially higher than in individuals with either HIV or schizophrenia alone. And among people with HIV, having a co-occurring psychiatric and substance use disorder substantially increases risk of death. So what do we know about psychosis in the context of substance use? Well, of course, psychotic symptoms are more common among people who use substances, as we would expect. Amphetamines, cocaine, alcohol, and cannabis are associated with the greatest risk. Severity, duration of use, age at first use, and genetic vulnerability to psychosis also increase the risk of developing psychotic symptoms if you use substances. And in studies, when they follow folks that initially present with a diagnosis of substance-induced psychotic disorder, about 10% of them do go on to develop a chronic psychotic illness and meet criteria for something like schizophrenia or schizoaffective disorder, even if they stop using substances. The lowest risk of conversion to a chronic psychotic illness is for alcohol-induced psychosis, and the highest risk is for cannabis-induced psychosis. And we think that this highest risk with cannabis is because for the folks that develop psychotic symptoms with cannabis use, there's probably already a genetic predisposition to psychosis. What predicts converting from just having a substance-induced psychosis to having a chronic psychotic illness is early age of being diagnosed with substance-induced psychosis, male sex, ongoing substance use, and family history of psychotic illness. So this is just a look at the different substances that folks commonly use and how likely they are to experience psychotic symptoms. And this is compared to the incidence of psychotic symptoms in the general population, which is somewhere between 5 and 9%. So just to be clear, this isn't the prevalence of schizophrenia, just the psychotic symptoms in general. And so as you can see, for people who use substances like cannabis, cocaine, opioids, and amphetamines, but wouldn't meet criteria for a substance use disorder diagnosis, the incidence of psychotic symptoms is similar to what it is in the general population, maybe a little bit higher. However, by the time you meet criteria for a substance use disorder, and this study came out back when we still categorize substance use disorders as like moderate dependence and severe dependence, by the time you would meet criteria for severe dependence with amphetamines, your risk of psychosis was essentially 100%. And I think that we see that in our patients all the time, right? For our patients that are using stimulants heavily, most of them will go on to develop psychotic symptoms at some point. So how about the reverse? So substance use in the context of having a psychotic illness. Well, substance use is more common among people with psychotic disorders than in the general population. For individuals with a schizophrenia diagnosis, up to half of them will meet criteria for a substance use disorder at some point in their life. And for people with psychotic illnesses that use substances and have a substance use disorder, it's associated with poor outcomes, increased symptom severity, and lower treatment adherence. And as far as what substances people with psychotic disorders use, most common is nicotine, followed by alcohol, cannabis, and cocaine. So which is it? Is it that somebody has a psychotic disorder and is using substances, or is it a substance-induced psychotic disorder? Well, the DSM-5 definition of substance or medication-induced psychotic disorder is that you have to have hallucinations or delusions that develop within 1 month of either intoxication or withdrawal from the substance. They're not better explained by psychotic disorder and are not exclusively during a delirium. So when studies look at comparing substance-induced psychotic disorders to having a primary psychotic disorder and using substances, folks with substance-induced psychosis tend to have a weaker family history of psychosis. They tend to have better insight into their symptoms, and so you can sometimes observe that in your patients, especially I would say for patients that are kind of on the early end of experiencing substance-induced psychosis. They often will maintain pretty good insight that, like, let's say when I use meth, I get paranoid, right? Whereas you wouldn't necessarily expect a person with schizophrenia to have that kind of insight. They tend to have fewer symptoms, and they tend to have more other psychiatric symptoms like depression and anxiety. So this covers kind of a similar breakdown. In this study, they specifically looked at idiopathic versus cannabis-induced psychosis and looked at the differences in symptomatology. But I would say, kind of looking at this, it broadly applies to most substance-induced psychosis. I mean, some of these things are pretty obvious, but I think some things that are maybe worth pointing out is that, of course, when psychosis is substance-induced, it will appear or worsen during periods of heavy substance use and theoretically should get better if the person is using less or not using at all. And antipsychotic medications tend to work quite well for primary psychotic disorders like schizophrenia, and they don't necessarily work all that well for substance-induced psychosis. Now, we will see later on that there is still a role for antipsychotic medications for substance-induced psychosis, but they just don't work quite as well. The other thing that's worth pointing out is that with primary psychotic disorders, we tend to see more thought disorders. So people that are cognitively impacted by their illness, they may kind of present with that sort of like very flat or blunted affect. They may have like trouble putting their thoughts together and have cognitive issues. Whereas for people with substance-induced psychosis, primarily what we see is hallucinations and delusions, especially paranoid delusions. And then, like I said before, people with substance-induced psychosis can have better insight into their symptoms. So why does it matter? Why do we need to think about, well, is it a primary psychotic illness or is it a substance-induced psychosis? Well, hopefully having the correct diagnosis will lead to the correct treatment. So if somebody has a primary psychotic illness, they will probably need to be on some kind of medication for most, if not all of their life. They need to have, regular mental health follow-up, including with psychiatry. Whereas if somebody has a substance-induced psychotic disorder, the ideal treatment for them is going to be substance use disorder treatment. And what's important is they can taper off their medications when they are stable, provided they are being closely monitored. And of course, we want to avoid unnecessary exposure to antipsychotic medications and the side effect burden. And I think that this is what I see all the time too, right? As folks at some point in their life, when they were using substances heavily, were experiencing psychotic symptoms, were put on an antipsychotic medication. Now it's 10 years later, they've, been on this medication, they've gained a bunch of weight, they may have had other side effects, whatever, and they are no longer using substances and they're not having any psychotic symptoms, but it's just that no one's ever thought about hey, do you still need to be on this? Or can we get you off of this? And often they will have diagnoses in their chart like schizophrenia or schizoaffective disorder or bipolar disorder. And it often takes a lot of digging and getting to know the person to figure out if that's truly a diagnosis that they have, or was their presentation initially primarily substance-induced. So approaching patients presenting with psychotic symptoms and using substances. So, of course, psychosis can be quite dangerous, and so we want to assess safety. And does this patient need to be hospitalized for psychosis, or do they need inpatient substance use disorder treatment? Most often comes up for alcohol, sometimes can come up for other substances as well. As far as assessing safety specifically for psychosis, because it can be a little bit different. It's actually not super common that I see people with psychotic symptoms presenting with like suicidal or violent thoughts. It's more thinking about the kind of psychosis do they have? Does it pose a danger to them or others? The things you want to watch out for and the symptoms that tend to be the most dangerous are command auditory hallucinations, especially command auditory hallucinations to hurt themselves or hurt others. So if folks are saying they are hearing voices, you always want to ask if the voices are telling them to do anything, and if so, what are they telling them to do? And if they say, well, yeah, the voices tell me to hurt myself or to cut myself, then you want to get a sense of have you ever thought about actually acting on that? Have you ever gotten close to acting on that? Or do you feel you have awareness that this is a voice and that you're not going to act on this? And you can see it go both ways. Other symptoms that can be scary are paranoia. So especially paranoia. So people can have kind of general paranoia. People are following me. People are watching me. People are recording me. Or people can have paranoia about specific people. And that tends to be more dangerous. And so when I start to hear people express paranoia about specific healthcare providers, people in their housing, or anyone really, that's when I start to worry. And so that's when I will ask things like, well, have you ever felt like you needed to defend yourself or protect yourself in some way? Do you feel unsafe? Because most commonly, if a person with psychosis is going to act in a violent manner, it's going to be in response to paranoia and feeling like they need to defend themselves from somebody. And then, trying to get a good history when possible. Now, of course, if a person comes in and they are psychotic, you may not be able to get a good history from them right then and there. But perhaps when they stabilize a bit, you can get a sense of the timing of their symptoms. It's always good to know about, if they're using substances, when was the last time they remember that they weren't using substances, and what were their symptoms like at that time. Of course, symptoms may persist as long as the substance use continues, and may even persist if they stop using the substance, but you want to at least get a sense of did it get better? And I often just start by asking, hey, do you see any connection between how much you're using and what your symptoms are like? And sometimes people will very clearly say, oh yeah, absolutely. And then other times people say, no, it has nothing to do with that. It's a totally separate issue. The more kind of atypical presentations of psychosis may suggest substance-induced symptoms. So for example, we don't think of visual hallucinations as a big part of psychotic disorders like schizophrenia or schizoaffective disorder, but they're quite common in people who use substances. And then finally, I think it's good to know that these are not mutually exclusive, right? So somebody can have a primary psychotic disorder like schizophrenia and have a substance-induced psychosis on top of that. So certainly if a person with schizophrenia was stable and doing well and then started using substances, they could have an exacerbation of their symptoms, and you would still call that substance-induced psychosis. So, how do we treat these folks? Now, this is a tough question, and treatment guidelines are a lot less clear for substance-induced psychosis than they are for primary psychotic disorders. It's important to treat the substance use disorder if the patient is, willing and able to address that, and to get them into some kind of monitoring for persistent or recurrent psychotic symptoms. It is highly likely that they will need to be treated before you know for sure if it's substance-induced psychosis or primary psychosis. It's good to treat the substance use either way. And then when it comes to assessing the need for antipsychotic medication, so this depends, right? Because one, we know that the medications don't work as well anyway. And then there's this question of is it needed? So I would say for people, for example, if somebody presents and they say, I was using a lot of meth and I had all this paranoia and I was hearing voices, whatever. And then I stopped and now I'm, trying to get back on track. I've been avoiding it for the past month and I'm really noticing that those symptoms are getting a lot better. I'm not as paranoid. I still notice those thoughts come up, but I feel like things have gotten a lot better. That person may not need an antipsychotic medication. They can perhaps be monitored over time. And so you want to consider kind of the degree of impairment from their psychotic symptoms and kind of also what their preference is, right? So some people, they're just not going to take an antipsychotic medication no matter how much they may need it, which of course sometimes is an issue. But I sometimes, will tell people when they come in with these symptoms is I say, hey, it could be because of the substance you're using. It could not be. It's hard for us to say right now. I don't want to, expose you to this medication that is certainly not risk-free if I don't have to. So what do you think? Should we try to give it some time and see if you can cut back or stop using and see if your symptoms get better? Do you feel like that's kind of tenable for you, or is that just like not going to happen and you would prefer to just go ahead and see if we can get some medication treatment for these symptoms? So, and then of course you want to consider if a period of observation without a medication is one possible and two safe. So again, if they're presenting with those scarier symptoms, if the degree of their paranoia is, getting them kicked out of their housing and fired from their job and all those kinds of things, then of course you want to treat them. And then of course, dual diagnosis treatment programs are ideal for those with psychotic symptoms and substance use disorders, but they are hard to find. And then psychoeducation and building rapport are key. So people who use substances tend to have a lot of shame about using those substances, even if they're not always, they won't necessarily say that, but people do feel it. And so it often takes some time to kind of build a relationship with these folks and really get them to trust you and for them to feel like you're kind of on their side. And so, sometimes people will come in and feel like their first appointment is like their doctor just like blaming all their mental health issues on substances and can kind of really turn people off. And so just kind of getting a good sense of what their goals are, what they're there for, and building that trust with them maybe before you get into some of the psychoeducation about what these substances are doing to their brains. And then as far as selecting a medication, so there's actually no evidence that certain medications are more effective for substance-induced psychosis than others. There is a higher risk of tardive dyskinesia in people who use substances, so that's something to watch out for. We typically start with second-generation antipsychotics, and there's no consensus about duration of medication treatment if you do suspect that the psychotic symptoms were substance-induced. So typically what we look for is risk factors, functioning, and patient preference. And so I would say functioning is a big one. And of course, also are they still using the substance that you presume caused the symptoms or not? And so, if they are no longer using, they're getting treatment for their substance use disorder, and they start to say, hey, I started risperidone for this paranoia, and now I'd really like to come off of it. I kind of look at okay, where are they in life in terms of are things a bit stable? They have housing, they're taking their medications consistently, they really haven't had these symptoms for a while. I will start going down on the dose. I don't typically discontinue the medication all at once, but I may decrease it little by little and then see them maybe a little more frequently while I'm doing that to make sure that those symptoms aren't returning. Specifically for amphetamine-induced psychosis, since this is, I would think, what we see most commonly, at least this is what I see most commonly, there is randomized controlled data for olanzapine, haloperidol, aripiprazole, quetiapine, and risperidone. They all reduced psychotic symptoms, and no drug was shown to be clinically superior. Some, but not all, studies showed more side effects with haloperidol, and so that's kind of why I said, we typically go with the second-generation antipsychotics like olanzapine or aripiprazole, risperidone. And then just a quick word on psychotherapy and other psychosocial interventions. So the best treatment for substance-induced psychosis, right, is not using that substance. And psychotherapy and other psychosocial interventions are often the best and sometimes the only treatments we have for substance use disorders. And so getting people into that kind of treatment is important whenever you can. It's also interesting to know that a delay in intensive psychosocial treatment is associated with more negative symptoms, actually more so compared to delay in antipsychotic medication, even for people with primary psychotic disorders. So psychosocial treatment is very important. And then there was this study that looked at motivational interviewing in addition to treatment as usual in young people with psychosis who used cannabis, that did show that those who got motivational interviewing had a greater reduction in cannabis use and greater confidence for change at 3 and 6 months. Fortunately, it did not hold out at 12 months. I just wanted to share this resource for any of you that may be interested. This is the UW Psychiatry consultation line. So it's for any provider in the state of Washington. You could staff 24/7 by UW psychiatrists. If you ever have a question about a patient, just feel like input from one of your psychiatry colleagues would be helpful. We are here for you.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.